Okay, we're a little out of order, but now we'll move on to best of the AUA bladder cancer. And with today's last talk about bladder cancer, what I'll focus on are the recently released AUA guidelines for management of non-invasive bladder cancer. Again, no financial disclosures. Objectives, we'll review the non-muscle invasive guidelines, we'll discuss them. With regards to the procedural stimulation for improvement of TURBT, that's the video that we watched a little earlier. So again, looking at bladder cancer from the clinical states model, I have a clinical states model for every GU malignancy. So we looked at the prostate earlier, but let's look at bladder now. So again, initial evaluation of bladder cancer, you have non-invasive, invasive, and then metastatic. And again, looking at where the trouble comes, where do people die from cancer? So typically not here, typically death is due to other causes. However, there's a select subpopulation of people with non-invasive urothelial cell who will progress to muscle invasive and die from disease. But it often happens here and also here. So treatment of non-muscle invasive disease. So there are a couple of different things, and it's color-coded. So we'll look at the AUA bladder cancer guidelines in pink, the older ones, they're in pink. However, the new AUA and SUO guidelines are in orange. So we'll start off here with cystoscopy, biopsy, and we'll discuss initial TUR. So cystoscopy. Cystoscopy is the gold standard. There's no substitution for it. We're looking at new markers, but still there's no substitution for cystoscopy. Next, cold cup excisional biopsy with fulguration is okay for small tumors, just small tumors, that's it. There's been some talk about office fulguration of tumors. Say you have someone who has recurrent low-grade TA disease. These patients can undergo laser fulguration in the clinic, but not in the operating room. Again, it's only for select patients with low-grade small papillary disease. Small low-grade tumors, we've shown that you can actually watch some of them. Say if you have an older patient who has, morbidity from other diseases and they're significant operative risk. If they have a history of low-grade disease, then you can watch them for a while to decrease the morbidity associated with going to the operating room. Again, select cases. You want to perform a good TUR, and you want to repeat the initial TUR if the initial one is incomplete. So the role of enhanced cystoscopy. So there's white light cystoscopy, but we also have blue light and fluorescence and narrowband imaging. So both narrowband imaging and blue light detect more CIS than white light. This is proven to be true. It's helpful. Blue light is helpful sometimes when you're doing the initial TUR because it can help you see something that you miss. And you may consider the use of narrowband imaging to increase detection and decrease recurrence. I say this because there are some scopes now, some flexible scopes that we use in clinic, and they have a narrowband option. So high risk, TA, T1, and CIS disease. Muscle is absolutely required for accurate T1 staging. Reason being, there's a significant risk of understaging. That's why we go back and re-resect. And if you want to think about when you go back and re-resect, you want to go back and re-resect within 6 weeks. Looking at high-risk TA and T1 tumors, again, they should be re-resected within 6 weeks. We briefly mentioned the risk of residual disease and understaging. And looking at persistent high-grade T1 or T1 with CIS for lymphovascular invasion. Lymphovascular invasion is bad in bladder cancer. If you see it, if your pathologist comments on it, that's a bad thing. Most high-risk TA high-grade tumors in CIS should be treated with a 6-week induction course of BCG. Again, strong recommendation for it. And I'll show you the combined AUA SUO guidelines sort of on a spreadsheet, on a flow diagram, so it'll make a bit more sense. I'm just highlighting some of the key points here. Tumors in diverticuli. So these are a little misleading because you can see a small lesion in the diverticulum and you can think to yourself, oh my gosh, that looks like a T1. But because there's no true muscularis there, sometimes these tumors are aggressive and they become T3 before you know it. So rules about tumors in diverticulum. TA disease can be safely removed with caution if technically feasible, but these are often very difficult to remove because you can try to do a resection and it's very easy to perforate a diverticulum. Moving forward, T1 disease, if high grade, you think it's T1, but it's actually T3 disease. So it's easy to understage it. If you're considering partial cystectomy for someone with a tumor and a tick, in this case you want to biopsy the neck of the tick and also perhaps consider random bladder biopsies because you're thinking of managing this with a bladder preserving procedure. Cystectomy is occasionally required. So complications, bleeding, bladder perforation, and the key thing is to distinguish intraperitoneal versus extraperitoneal perforations. What has changed is, when I was training, the thought process was if you have an extraperitoneal perforation, put a catheter in and you're fine. But if you had an intraperitoneal rupture, then you had to open. You always had to open, explore, and close. That's not always the case. Nowadays, even if you have a small intraperitoneal tear, you can manage that conservatively. So how do you identify them? A couple of other key points. One thing also that's been discussed recently is TURBT syndrome. I wasn't aware of this with training. I thought that there was TUR syndrome with prostates, but actually something similar can happen when you're doing bladder resections as well. And looking at seeding, the highest rate of seeding actually occurs when you do an open operative repair of an intraperitoneal perforation. So comparing them both, extra versus intraperitoneal. This is extra, this is intraperitoneal. And the key point, the pathognomonic feature, is that you can start to see the loops of Bob. So here, you kind of can start making out the loops of Bob with the intraperitoneal rupture. So, bladder biopsies, directed biopsies and biopsies of suspicious lesions, always appropriate. Random biopsies, again, random biopsies, not appropriate if the mucosa is normal and the tumor appears papillary and non-invasive with a negative cytology. You don't need to do it in these cases. It's appropriate when the cytology is positive, but you can't see anything. Cytology is positive, highly suspicious, but you can't see anything. That's when you want to do random bladder biopsies. And it's also, again, appropriate when you're considering a bladder-sparing sort of technique. So urinary marker tests, we briefly discussed these during the previous lectures. There are only a few that are FDA approved. NMP 22 in the bladder check. One is a quantitative, the other is point of care, BTA track and BTA stat. And then there are a couple of cell-based ones. There are several that are not FDA approved. This is the thing that you need to remember. This is a point that I made earlier. It deals with the sensitivity and specificity. With regards to specificity, cytology is the best. However, these are a little more sensitive. So, points here. You cannot use a marker in place of cystoscopy. Cystoscopy isn't going anywhere, it's necessary. You must continue to do it. And markers with low-risk cancer, you know, it's not always necessary. And it's helpful to assess the response to BCG and sometimes when you have an adjudicate equivocal cytology. So old and new grading. We went over this a little before. The old grading system, the new. Papilloma, pum lumps, low grade and high grade. They all behave differently. Yeah, the data was different. So risk factors for recurrence and progression. Grade. So looking at, you know, papilloma versus high grade, the risk of recurrence. The key thing here is progression at 4 and 8 years. Papillomas and pum lumps, rarely. Low grade, it can happen. High grade, for sure, absolutely. Stage plays a role. Also, recurrence rate. How soon does something recur? Is it happening within 6 months to a year of an intervention? Multifocality is very important. Also, size. Typically, one should think less than 3 centimeters versus more than 3 centimeters. And also, if there's tumor present at the initial 3-month scope, not a good sign. So risk classification. So there are a number of factors. So there's low risk and high risk and intermediate risk. I suggest that you learn high risk and low risk, and anything in between is intermediate risk. So with low risk, low grade, Solitary, primary, small, TA, or PUMA. Progression, low, less than 5% at 5 years. High risk, T1 high grade, recurrent, multifocal, large, greater than 3 centimeters, CIS, prostate, urethral involvement, lymphovascular invasion. Again, this is new. I don't remember us sort of being concerned with lymphovascular invasion that much in years prior, but it's a hot topic now, it's important. These guys progress 25 to 50% at 5 years. So intravesical chemotherapy. These are just some of the highlights from the new guidelines. You know, some testable points, mitomycin is an alkylating agent, and it's not absorbed, and that's because of the molecular weight of 334. So mitomycin, the key thing, there's not a lot of absorption because of the molecular weight. Biotipa, the molecular weight is 189, it's absorbed, this leads to myelosuppression. That's something that they test all the time. So mitomycin, not always absorbed because of the weight. Biotipa is absorbed, causes myelosuppression because it has a low molecular weight. Key points to remember. Some other things. You know, single dose mitomycin or epirubicin within 24 hours post-TUR for low intermediate risk. This is an AUA recommendation. It's BCG contraindicated if there's a suspected PERT. Induction treatment, usually 6 weeks for intermediate, but not low risk. If you're thinking low risk patients do not get BCG. Intermediate and high risk patients do. Moving forward, maintenance treatment. You should consider maintenance treatment if you're dealing with high risk or intermediate risk, and it varies. Some people, suggest maintenance treatment for a year. Others follow SWOT criteria and say that you should give it for 2 to 3 years. Again, it all depends on if you're dealing with intermediate risk or high risk. So toxicity, general, irritative symptoms from cystitis, tissue necrosis can occur with MMC and adriamycin and epirubicin, not Biotipa. Agent-specific toxicities, mitomycin C, hypersensitivity dermatitis, comes up on the boards all the time. Adriamycin allergic reaction, I've never seen it, but it can happen. Biotipa, myelosuppression. You got to monitor the CBC weekly. This is tested, it's on every exam. BCG induction, 1 weekly treatment, times 6. You typically want to wait 2 to 6 weeks after the TUR. You may repeat it, say if you have someone, you give them a 6-week course of induction therapy, something comes back, you can give another 6-week course of induction therapy. Usually after 2 courses, and if they fail, cystectomy. We should strongly suggest cystectomy. Again, maintenance. 3 weekly doses at 3, 6, 12, 18, 24, 30, and 36 months. This is the SWOG protocol, which is preferred in intermediate risk, 1 year, and high risk, 3 years. The dose. It all depends on your institution. At my institution, usually it's 50 milligrams and 50 milliliters, and sometimes patients can't tolerate the full dose, so I've halved the dose, and sometimes I've cut the dose in thirds to help the patient tolerate it better. Anecdotally, they do okay, but the literature says that if you decrease the dose, the response may not be as good. So the mechanism, how does BCG work? This is another point. It sort of stimulates a T helper type 1 response. So it causes an increase in interleukin 1, interleukin 12, and interferon gamma. And this, sort of results in a local inflammatory reaction within the bladder that kills tumor cells. And you don't want to confuse this because there's a T helper 1 response and there's a T helper 2 response. BCG stimulates the T helper 1. So contraindications, of course, traumatic catheterization, blood plain, absolutely not. Recent gross hematuria, avoided. This is something significant. Immunosuppression. So if someone has mild immunosuppression, it's okay to move forward. You just have to see how they do. But significant immunosuppression, you really, really want to be careful with it. Prior BCG sepsis, reflux is not a contraindication for it. So BCG toxicity, they're non-infectious issues, cystitis. If someone has cystitis, you want to try anticholinergics and pyridine first. sometimes adding a quinolone can help. I haven't done this myself, I've read about it, but supposedly it works for some. Again, we spoke about the BCG dose reduction, and you can space out the treatments 2 weeks apart. Again, this is not something that I've done in my practice, but I don't know the response that you would get spacing them out 2 weeks compared to every week. But I guess it's better than nothing. Key sign of BCG sepsis, flu-like symptoms, especially the high fever or recurrent fevers after 24 hours. Typically 39.5 Celsius is the cutoff. And there's hypersensitivity that can occur as well. So BCG infection, say if you do have it, typically needs about 3 to 6 months of anti-TB meds. The single agent isoniazid, moderate cases, but usually double and triple therapy with isoniazid, rifampin, and enbendazole for the severe cases is the answer. You do want to supplement with vitamin B6. This is something that's testable. Cycloserine before was thought to be helpful, now it's ineffective. And pyrazinamide, ineffective. And oral steroids can sometimes help with some of the side effects. So organ-specific BCG complications. We've been speaking about elevated PSAs and what things cause elevated PSAs. Well, you can have BCG prostatitis. It can result in an abnormal digital rectal examination, and it can raise the PSA temporarily. So if you have the elevated PSA in someone who's had BCG recently, I would biopsy them right away. I would give them some time to repeat the PSA a few months later, because the PSA can actually go down. And the prostatitis spontaneously improves over 3 to 6 months or so. Epididymitis is a possibility, involvement of distant organs, and sepsis. Again, can be fatal, usually the result of traumatic catheterization. The early use of steroids is life-saving. So, intravesical treatment by risk group. Remember, low risk, intermediate risk, and high risk. Try to remember the low risk and the high risk, intermediate is everyone else in between. Low risk group. Single dose within 6 hours of TUR, AUA option. Or TUR alone, and you just wait 3 months to repeat it. Intermediate risk group. Single dose chemotherapy, but likely a 6-week course of BCG. High risk group, I just say, 6-week course of BCG after going a resection. So, non-muscle invasive bladder cancer, NCCN guidelines. So, clinical stage TA, low grade, you resect. You can sort of watch or give 1 dose of the intravesical chemotherapy, reassess in 3 months, and then your follow-up will depend on what you see at that 3-month time period. TA, high grade, incomplete resection, repeat it. If no muscle in the specimen, I would say repeat it. BCG is preferred, mitomycin or observation are options, but again, high grade, I say go with BCG. T1 low grade, repeat TUR. In some cases, T1 high grade, you can discuss cystectomy, but I typically in practice give them a shot with BCG first. Key thing is re-resecting, going back after yourself, is extremely important because things can be upstage. BCG or cystectomy, BCG preferred. So, appropriate indications for cystectomy in non-muscle invasive disease. So, remember from our previous talk, we spoke about some of the variant histology: micropapillary, small cell, squamous cell, adenome, and nested variants. Lymphovascular invasion on T1, it's a very, very bad sign. So, you can consider neoadjuvant chemo. I don't know if I would do that, but I would certainly speak to the patient about maybe needing a cystectomy at some point. High-grade T1 that is incompletely resectable, persistent, multifocal, or associated with CIS. BCG failure times 1 of T1 high-grade, cystectomy. BCG failure times 2 of any high risk within 1 year of 2 cycles, cystectomy. Prostatic ductal involvement, cystectomy. And also, folks with dysfunctional bladders who are essentially bladder cripples, you may want to consider cystectomy a little earlier on in this patient population. So the impact of delay in cystectomy. I typically say if you've identified someone who, needs a cystectomy, you would rather do it sooner than later, because waiting and delaying therapy, it's been shown that that leads to a worse outcome, especially when you're talking after 2 to 3 months. So if someone needs a cystectomy, you want to get these patients to the operating room as soon as you possibly can. High-risk disease, a comment, and delay of more than 2 years after presentation of high-risk disease is associated with reduced cancer-specific survival. Of course, that should be no surprise. So surveillance. So upper tract studies. So, they say that none are required for low-grade patients, but when you have someone with a lesion or with hematuria, before you do the initial TUR, you don't know if it's low-grade or not. So oftentimes these patients in practice are imaged before you get into the operating room. Again, choice of imaging. Nowadays, CT urogram is preferred with delayed images. MRI is a possibility. If you can't do that, you do retrogrades. So just following up, no follow-up if you have someone with low-risk disease. Someone with intermediate or high risk, every 1 to 2 years. With the intermediate risk, you can image the upper tracts every 2 years, but if someone has high risk and you're following them with scopes in the office, you want to do an upper tract imaging study every year. And if cytology becomes positive without visible lesions in the bladder, you certainly want to image and you want to go fishing and look, because there's something there. It's just a matter of where. So surveillance plan based on risk, low risk, 3-month cystoscopy. If it's negative, you can wait 6 to 9 months before you do the scope again. Intermediate risk, 3-month cystoscopy. If it's negative, every 3 to 6 months times 2 years, then you can space it out after that. High risk. With the high risk folks, I typically take a look every 3 months for the first 2 years and then stretch it out after that. Low risk, cytology is a negative, but you know what, I'll be honest with you. When I'm following low risk patients and I take a look and I scope them in the office, I send the cytology anyway. Intermediate and high risk, you should send the cytology with every scope. Biopsies, directed for suspicious lesions on cystoscopy, random biopsies in some cases, especially if the cytology is positive, but you can't see anything. This is a situation where using narrowband imaging or blue light cystoscopy would be helpful to see something that perhaps you can't see with the typical white light cystoscopy. Workup for positive cytology. So I don't know how your pathologists read cytology here, but you have negative. At my institution, we have atypical, which I don't, worry about. Then there's sort of low suspicion, intermediate suspicion, and high suspicion. So if they tell me that low, I think, okay, there's probably a 30% chance of something being there. Intermediate, maybe 50, and if they say definite, I'm thinking there's a 90% chance that something is there, I just have to find it. False positives can occur with stones or instrumentation. And, when it comes to following patients who've already had radical surgery and they have urinary diversions, it's extremely important that the pathologist is aware of that and comfortable with that, because that can alter sort of what they see and how they read it. So localizing the source of positive cytology. Well, the bladder is the most common, random bladder biopsy. Upper tracts, you want to check selective cytologies of the upper tracts and also image. And you can consider ureteroscopy as well. What I typically do is if there's something that's there, I'll go in, I have a positive cytology, but the scope is negative. So what I'll do is I'll take that patient to the operating room. The first thing that I'll do is I'll do selective upper tract cytologies on both sides, and then I'll do random bladder biopsies. I'll get the random bladder biopsy result back, and I'll also get the upper tract cytology result back. And if something is there on one side or the other, I'll scope that patient. I'll do a ureteroscopy rather. Prostatic urethra biopsies, we do those at times. And then, topical BCG if you find something. So, treatment of intravesical therapy failures. So, BCG failures will seldom respond to mitomycin C. BCG failures ×1 you can give them a second chance with another induction course. BCG failures times 2, going for a third course isn't really helpful. Again, in a patient like that, I would counsel them for a cystectomy sooner rather than later. Patients with high-risk disease should be offered cystectomy after BCG failure times 2. And patients with recurrent, persistent or recurrent, intermediate, high-risk, non-muscle invasive cancer, you can consider clinical trial enrollment or intravesical chemo. This is a key point. Valrubicin is the only FDA-approved medicine for BCG refractory CIS. Methods of chemoprevention. There's some stuff in the literature regarding this topic. Antioxidants, although you have to be careful because of hepatotoxicity with vitamin A. Smoking cessation helps. Higher intake of fruits and vegetables, fat, cholesterol, that can impact your risk. And there was also something about non-chlorinated water. Not sure if I agree, but I always tend to think that drinking more water is good. So that's it for that. Any questions?
Yeah.
Yes.
Regarding first-time failure BCG, can we try it once more?
Yes.
In guidelines of 2014, it was for cystectomy. It was not for another course.
So
is it for another course? Can I try it once more?
you can try it once more, but it depends on what you had. So you had you resected BCG. It failed BCG. How did you know it failed? What did you see? What did you get on your second biopsy?
I found the recurrence of the same tumor, the same T1, G3, for example, or anything.
Okay.
Yeah. Can I try it once more after TURBT?
You can try it once more. The likelihood of it working, who knows? But you can try it once more, but I would also counsel the patient at that time that a cystectomy may be in the future, the near future. Yes?
If you case big perforation during intraventricular, what was next? Expectation or this is cystectomy or to wait for that?
So your question was, you're doing a TURBT, you have a large intraperitoneal perforation, correct? So again, in the past, that was an automatic indication for an exploratory for that slat going in and repairing it. If it was a small injury, you could maybe watch it, manage it conservatively. But if it was a large injury, I would go in and I would fix it. I would close it. I would not do a cystectomy at that time.
What's the cutoff in this issue, especially? And when to open and when to leave it? This tumor cells, which is present inside the bladder after resection.
Right.
This is not only for sepsis and peritonitis, but also for tumor cells present after resection, and this opened over the peritoneum. What is the guidelines in this issue?
Right. So I think in this situation, the guidelines are a little hazy. And I think that that's a function of surgeon preference. In terms of size, again, a small perforation, conservative, a large perforation, I would open. I can't give you an exact size and say, okay, if it's 3 centimeters or 4 centimeters, I open for sure. I can't do that. And it's difficult to assess the true size of perforation if you're looking. The other question, though, if you're dealing with someone who has a high volume of disease and you perforate, I still say you go in and close. The risk of seeding is high, but doing a cystectomy at that time, I don't personally think it's the right thing, because going in, you haven't appropriately counseled the patient, you haven't prepared the operating room, so you have a perforation, you want to fix it, but I don't think you're ready for an exam and accounted for something. So I would not do a full cystectomy at that time. Any other questions?
I have a question for you. Sure. For cytology for patients with new bladder or county, how accurate, how reliable?
So that's a very good question. The question was how reliable is cytology in patients who have neobladders or condyles? And I honestly don't know. it's something that I use. If someone is highly suspicious for it, for recurrence, then I'll image the upper tracts and I'll take a look at the stop. But it depends on the level of suspicion. I don't know what the data shows. Yeah, very tough.
The other thing is convert papilloma. Do you have any special precautions?
In terms of special, I don't think that's considered necessarily something malignant. So, you know, if you resect, you just will, you know, follow after that.
Any special extra follow-up?
Not that I can think of, not off the top of my head. Okay. Oh,
Yeah,
sure.
What your opinion about BCG could be adopted in health centers in Egypt? We give after BCG after introduction dose of 6 weeks, we give a monthly dose for 1 year for the intermediate risk and for 3 years for the high risk. Monthly dose, not like swag protocol as at 3, 6, 12, 18. What your opinion about this protocol? A monthly dose for 1 year for intermediate risk and a monthly dose for 3 years for high risk.
So if that's your protocol here, I mean, just thinking about it, I think that that's actually very good. I think that that's something that's probably more tolerable for the patient. In terms of comparing it to the swab protocol, we would have to flesh things out and look at data. But thinking about it intuitively, from the patient's perspective, I think that's a good thing. All right.
Thank you very much. We are going to have a coffee break and we'll return back at 3:30.